You are listening to the Health4All podcast, and this is your host, Sanat Kumar. I hope you enjoy listening. To all our listeners of the Health4All podcast, a very warm welcome to you once again for our fresh and brand new episode. Today, I'm talking to somebody who's not just trying to do work in healthcare or trying to lead healthcare companies, but is making significant change not just in his career but across whatever he does to ensure that access, affordability, as well as accuracy, and more important, availability of healthcare is an important aspect that he's addressing through the work that he does. I'm excited to have Edward. He comes with over 25 years of experience, holding leadership positions across large corporations, startups, investment houses, both in Indonesia and outside of Indonesia, right? More recently, for over a decade, Edward is focusing his passion, drive, as well as all the rigor that he has in supporting and building and driving change across not just private hospital chains, but also how he can make a difference in the BPGS hospitals, which is the government specific hospitals. Edward is also the founder of Unimedica Hospital Group. And now he's driving what we call as capex, low capex intensive model for diagnostics as well as cath labs. Edward, I'm super excited to speak with you, not just because we both love healthcare, we both like and do work in healthcare, but also because you are consciously making a decision in your life to go after something that is important to improving the quality of healthcare for a country like Indonesia. So welcome to the Health4All podcast. And I'm excited to speak to you for the next 60 minutes.
Thank you, Sana. Likewise. Thank you for inviting.
Wonderful, wonderful, Ed. Ed, like I said, I'm going to call you Ed throughout this conversation. So your journey in healthcare, right, started maybe over a decade now. It's been about 10 years. When you decided to come back to Indonesia in 2011, first of all, what drove you to come back? Because a predominant part of your career was in the US, and then you decided to come back home. And particularly, your first position you took on is in a space that is absolutely new to you, which is healthcare in the Siloam group. Walk me through the story, the journey, what made you choose to come back, and why did you choose healthcare?
Okay. Let's make this as simple as possible. 2008, there was the mortgage crisis. So, I own a business involving cleaning service, and it was shaky. So I told my wife, maybe this is the good time to go back to Indonesia and let's make baby as well. So back then we didn't have any child yet. So my wife said that, okay, considerably it's going to be good decision. At the meantime, she was doing a pre-med. So so we thought that, well, okay, let's continue in Indonesia. So in 2008, I was back to Indonesia with my wife. My wife immediately continuing her study in also UPH. And UPH is also associated with Siloam Hospital Group. And the good part, she was a very good student. She won a couple of gold medals, Olympic in competitions for medical environment. So the school actually look at her as very bright a student. So that is why they thought that, well, you must be having a good husband and smart one. So, the dean, who was the wife of the Siloam CEO group, and then they said that, hey, Ed, why don't we chat, and then let's see if you would like to come working in Siloam group. So it started by that. I went to the interview, and then everything went, I would say, great since then. Yeah.
Wonderful, Ed. A great story. So So behind every successful man, there is definitely a woman involved over here, right?
Agree.
Right. So was healthcare your passion at all before that?
Mm.
Of course, it's been in the family and you've seen your wife do it. But at any point in time, because from cleaning services to healthcare is a massive shift, right? Was it somewhere deep down inside your passion to serve the country and its healthcare needs?
Well, my basic thinking at that time was just, hey, a man should earn income for the
Yeah,
family. As
yeah,
simple as that.
yeah.
And I was honestly uh, was afraid
Mm,
entering into this healthcare setting. It's a hospital, big hospital, good brand
mm,
as
mm,
well. So with my little knowledge, I said
mm,
to my superiors that, like, please let me learn as much as possible, and
mm,
then tell me what to do
mm,
specifically, because I don't know anything else other than stethoscope at that
mm,
time.
mm, mm,
So I would say with the support of my leaders and then also co-workers,
mm, mm,
I'm here today. So it is not starting with passion,
mm,
but it was, I would say, just like a basic instinct that
mm,
I need to
mm,
do it. I need to
mm,
work. But when I started to get involved in Siloam projects and
mm,
then
mm,
looking on how Indonesia
mm,
really
mm,
needs and
mm,
then have actually the big needs in the healthcare setting, like I thought, no, okay, let's
mm,
do this
mm.
with all my life. So I was just thinking of giving pretty much my best during my Siloam time. Mhm.
Superb, superb. Mm, so during your time, and that was in
Mhm.
2011, right?
Correct.
And you started your journey in Siloam, and you spoke about how you uncovered the need and you found that passion within yourself, right?
Mhm.
Um, what did you see were some of the aspects that drove you towards saying that, yes, I think this can be something that may work?
Okay. Uh, when Siloam in 2011,
Mm,
I saw that there is a big ambition
mm,
for Siloam to be the leader in
mm,
the healthcare setting,
mm,
and also from the founder, which
mm,
is also
mm,
Pa James Riyadi.
mm,
And he believes that Indonesia has that kind of huge needs, and then he sees that this is also an opportunity. So definitely idealism
mm,
compare with also, I would say, profit. So
mm,
that's, I would
mm,
say, the main trigger.
mm.
And what I saw during 2011 was Siloam was not ready actually to
Yeah,
do this kind of big expansion.
yeah,
People were focusing on getting the operational side and
yeah,
then giving a better quality services, but
yeah,
not toward expansion. And then I would say with that kind of starting idea, let's do expansion.
yeah, yeah,
I was given an empty list at
yeah, yeah,
put up the cities that you think that we should expand
yeah,
into. You're
yeah,
like, okay, let's do that. You're like, so
yeah,
I drew about 77 cities that
yeah,
we thought it would be good,
yeah,
matching with the land banks of
yeah,
Lipo Group as well.
yeah,
Um, with that kind of to say, when I was seeing that, wow, in this 77 list, I don't see too many so-called good hospitals.
yeah,
And in 2011, there is a good understanding that government hospital was not a good hospital.
correct.
So it's pretty much when you are checking in,
Yeah.
you might not be checking out. Yeah, I mean, sorry to say, but
No,
that's
that's true.
2011.
That is
Yeah.
true. Yeah.
So pretty much the society was not having a good trust in the healthcare
Mm,
system back then.
mm,
So with the kind of expansion of Siloam, building a modern hospital, setting up as a good
mm,
leader,
mm,
example in the
mm.
market, so it actually bring me into certain kind of excitement as well. Okay, good branding. We bring this new brand into a city, and even let's say in Makassar, in Manado, when
Mm,
they hear about Siloam, they know that Siloam is a good branding back then.
mm,
Yeah.
mm.
Mhm.
No, that's fascinating, Ed. Uh, you're talking about 2011, where where the digital penetration was low, understanding in one click where your good hospitals are or where there are no hospitals, it was not easy 10 years back, right?
Correct.
So what was it like, to walk into a massive hospital, trying to build a brand, trying to expand, and more importantly, how were you perceived internally, and what, because it's somebody coming from no experience in health and is telling, what, guys, we need to go to Makassar, or we need to go to Banjarmasin, maybe, right?
Correct.
But what was that? How did the company perceive you? What was the reactions that you got from within the organization?
Okay. I would say everybody was a bit shocked when
Mm,
there is a mandate coming from the
mm,
top saying that
mm,
let's do expansion. And then
mm,
how many expansion actually being disclosed? 77.
mm,
I was a bit puzzled. Okay, 77. And wow, back then in 2011, Siloam had only about 7 hospitals.
mm,
So, and
mm.
this 7 hospital had been there for about 10 years. So, I
Yeah,
mean, it's
yeah,
not actually growing one a year,
yeah,
almost one more,
yeah,
like more than 1 year to grow
yeah,
a hospital. Well, luckily, I would say this kind of big dream, again, we have to be able to translate the request from the top. And
yeah,
then we try to deploy the planning, and we did the budgeting, we did the
yeah,
drawing, we did
yeah,
so-called the coordination together
yeah,
between the HR,
yeah.
making sure that the plotting would be making sense. Let's say if we open up in a new city, we could be not surviving if
Yeah,
we cannot
yeah,
be careful enough to learn about, hey, do they have enough specialists to
yeah,
accommodate
yeah,
so-called a modern hospital like Siloam?
correct.
So again, the screening, finding a methodology to find out which actually going to be the priority. Back
Mm.
then, like even Aceh was in
Yeah,
the list, like,
yeah,
but we see that, wow, okay, Aceh is going to be a bit tough.
yeah.
But again, so we pairing up, like somehow it comes up with Manado as
Mm,
the
mm,
priority,
mm,
Makassar also,
mm,
and then this from a dream being given by the founder, I would say the ability from the top management to be able to get the dream
mm,
and then
mm,
push it down, and
mm.
then everybody just, I would say, trying to support it. We understand it was just too big a dream, but
But
we
they
see
saw the
that, yeah.
conviction. But they saw the conviction in you. They saw the drive in you. I'm guessing, right?
Oh,
Because that's when MRCC was also, inaugurated, and
uh-huh.
you
Correct,
also
correct,
audited some of those assets, right? Based on my research.
correct.
Um, uh, so Ed,
Mhm.
having worked in private hospitals, you've also been in Mayapada, and one of the things that we see is, of course, there is healthcare, of course, healthcare, quality of healthcare, hospitals, it's getting better. But is it there yet? Not yet. We are still struggling with regard to multiple different issues, right? Um, just taking a little bit of a step back, even before hospitals, why do you think that primary care itself is so underserved at this point in time? Why are hospitals not pushing enough to actually spread the reach using primary care?
Okay. Private hospital, definitely they aim to get, I would say, better positioning.
Mm,
They don't want to risk not to get so-called enough revenue to cover enough EBITDA. That's,
mm,
I would say, the bottom line. So even before 2015, before BPJS time, hospital was even eager to expand into the good location, and they are
mm,
prioritizing the good location with the premium payers,
mm,
like Makassar,
mm,
Manado,
mm,
Bali.
mm,
And but again, I feel there was no interest at all to go to a second tier city
mm,
before
mm,
BPJS time. And
mm,
after BPJS time, there was a bit of shifting in strategy that they see that, well, okay, this is going to be the biggest payer of the healthcare. So why don't we consider in the expansion plan to get second-tier cities as well? What you had been analyzing is very, very to the key point that definitely there is still an underserved primary care in Indonesia. Why? Private hospital, I would say, has no willingness to go beyond the second tier. I would say it's going to be troublesome. One of the key issue on their consideration, if they open up in the third tier cities, will they get enough manpower to support the hospital? 120 bed hospital, it could carry about 400 to 600 manpower. 70% of them would be nurses, and in this small city to get that kind of many manpower specialized in the healthcare setting, it's going to be super tough. Definitely collaborating with the C-type hospital in Indonesia, the category A, B, C, and D. C-type hospital, they have also to get several of specialties. Again, opening up a general hospital, it's a bit tougher rather than opening a mother and child hospital. That is why in small region, many solo player, individual hospital was starting as mother and child. That would be easier, but again, it's not capturing pretty much the whole primary market. My sense is government needs to be involved. In the smaller region, for encouraging the private players to open up their newer facility. I put some kind of notes that government needs to do something. Let's say giving tax-free or less tax for the imported medical equipment. Again, Indonesia has no technology yet to produce, let's say, ventilator, MRI, CT scan, and we imported a lot, pretty much, I would say close to 100% from the US, from the Europe, Siemens, GE, Philips, pretty much the major brand. And again, we imported with a lot of cost. Plus, I never heard there is tax saving on importing those area. While Indonesia is, I would say, declaring that infrastructure in the healthcare setting is needed. The market of the healthcare needs to provide more access. But I would say the government has not been involved strongly in spreading out the so-called the establishment of the private hospital in the smaller region.
In the smaller regions.
Correct. And go ahead.
So I think you're absolutely spot on, right? If you were to, just for our listeners as well, if we were to quantify some of this from an access standpoint, we're at about 1.2 beds for every 1,000 people. And most of about 35 to 40% of our healthcare expenditure is still out of pocket. And private hospitals are good. However, it's not affordable for the middle, lower middle, and BPJS is still stabilizing, as you know. So some of the things that you said, what needs to change in order to actually make this work is government support, tax subsidies. And what else, Ed? Of course, you talked about manpower being a significant issue because quality of nurses, specialists being another aspect of it. But what can be that disruptive change according to you? And of course, your company, SME Medical, is doing some of that, right? We'll come to that very shortly. But what are the other things that you believe can be ways in which we can actually spread the reach faster?
Okay, sure. The statement of 1.2 beds for every 1,000 people, that kind of statement, I would say, is a bit cloudy. Why? Most of the beds are located in the first tier city. So again, this is the same issue, but when people read the statement, okay, well, Indonesia have 1.2 beds for every 1,000, But again, Indonesia is very huge, and then this is not covering. The statement is not covering Indonesia. So, getting back on what actually can be done aside of, let's say, the tax subsidies, definitely BPJS needs to improve their tariffs. Why? Since 2015, the first establishment of BPJS, there are not many so-called improvement in tariffs. We have inflation. We have, I would say, yearly costs of paying more, 5 to 10% of the salary for the manpower. So I would say, BPJS is not really digging enough into giving the solutions together with the Ministry of Health. For expansion, I believe government also needs to set up in the terms of why don't they involve in also giving incentive in the infrastructure. So if you want to get financing, let's say government needs to open up maybe government banks or government, to support this kind of expansion. We don't see that yet. And I would say this is going to be a wake-up call for the Indonesian government if they start to keep realizing that how big the population and then how spread it out Indonesia is. The hospital needs to be established in the smaller region. But again, private hospital, we thought those backups, they just think that, the EBITDA being so-called received from the third-tier hospital will be damaging their pretty much the consolidated book. I would say that's going to be tough. So government support is a must.
Ed, a lot of the thoughts that you just said, are absolutely spot on. And I actually authored an article in Forbes, which was called "The Wake Up Call for Indonesia's Healthcare System," and it is exactly similar and in line with what you just said, but powerful statements on what needs to be done. So now that we are anchored into BPJS, and I think you have now dedicated your time to making sure that BPJS hospitals need to be improved. Your entire company right now, SMU Medical, is focused on doing exactly that. And congratulations, because you won an award as well as one of the most innovative companies in the field of investment in healthcare operations back in 2021.
Yes.
So for the benefit of the listeners, right, what does SMU Healthcare do? And why is it changing and innovating the landscape of government hospitals in Indonesia?
Okay, sure. Definitely, this is an innovative idea for Indonesia, but it has been there in Singapore, in the US, so that it is not new. Pretty much what we do is preparing the capex. We bought what the hospital needs, and then we do revenue sharing. As simple as that. For example, in the city of Kendari, in the southeast of Sulawesi, they never had the equipment of cath lab for the whole province. So we did a feasibility study, we check around, and then the hospital has so-called one manpower, one interventionist for the whole province.
Oh, wow.
So yeah, and they did not have the cath lab yet. So if we had back then, if we had a stroke case, potentially the person will suffer. So we thought of, wow, this is going to be a good so-called solution. We collaborate with government hospital, and maybe we ask, why this big government hospital, they don't have yet a cath lab? Again, the issue of manpower. And then secondly, the issue of capex. For government hospital to request an equipment, it's not that easy as, okay, and like the local government has the money, let's ask for them. It goes to votings as well in the legislative. So it's a long journey for them. And we give a simple solution. You tell what you need, and then we do a calculation. If it is making sense, then we're going to buy you the equipment. You don't need to spend anything. Even we renovate, the facility to make sure meets the standard of operating, and you just play a part in the providing of manpower, and then making sure that there are many users of the equipment. So that's what we believe. And for Kendari, we actually did more. It was a big risk for us. We didn't have enough data on how many so-called incidents that would be happening. But again, with the belief of an idealism that we believe that this kind of big city needs so-called basic equipment such as a cath lab to actually give and save lives. As simple as that. Again, we give a lot of projections to the investor. Investor was agreeing, and the good part of the investor, one is a Japanese guy, Ataru is the name. His father was a medical doctor as well, and then he has certain calls on involving in this kind of so-called humanity project. So he was just very positive about this, and then we decided to move forward for this project.
So your decision, let's say for Kandari, right? For example, it started off with identification of an interesting location, collaboration with a hospital that actually needs this. You also mentioned that you were going to jump into a risky situation over there because you're not sure about the traffic and the utilization of your equipment, right? So with that in mind, Ed, what were some of the strings or the data that you had to pull in to make sure that your business case is sound, right? See, again, we're talking about getting into a BPJS hospital where data is weak, where the understanding of a cath lab and its impact to the society is also limited. Manpower availability to run a cath lab effectively and also analyze the results of the cath lab is also something that is not heavily developed, right? So how did you address all of this as you were building the business case for it? And how long has it been, before you answer that, how long has it been since you've established this cath lab in Kandari?
Kandari has been 4 years.
4 years already. Okay. And what utilization is it running at now?
I would say the utilization is about 40 to 50%.
Okay. Okay, great. Yeah. So walk me through that, Ed. So how did you assess how did you mitigate some of these unknowns, if I may?
Okay. As you said, BPJS doesn't have data. I would say good data.
Yeah.
Not also the Ministry of Health. So we depend a lot with our internal team to gather all the data, do the visitations, and then even doing the like counter clicking, how many people were coming into the cardiologists outpatients clinics. So like we try to get the sense on making sure that there is enough cases of cardio-related situations, and we believe that like by using that simpler, I would say, data, we would be needing to make a decision whether we should go forward or not. Back then, before 2019, BPJS was not that strict comparing to today. Opening a cath lab does not mean unnecessary. Immediately, we got a permission for BPJS to use the equipment for BPJS patients.
Got it.
So BPJS needs to prepare another statement basing on their visitation again, whether they are allowing that hospital to accept BPJS patient to the hospital cath lab. Pretty much that is both from SMU money. Back then, it was not a problem. So Kandari project was not too difficult. But today, we are evolving a bit. We have an understanding that BPJS somehow doesn't like the access for cath lab facility to be pretty much open all over Indonesia. maybe this is, like BPJS could complain about my statement, but this is what we feel in the market, that we understand that the cost of cardio-related procedure is above 50% of BPJS reimbursement. So 50% of their budget pretty much being spent into cardiovascular related. But again, we cannot deny the access to the public. BPJS need to put up full support on this area. Meanwhile, we actually ask BPJS, we ask Ministry of Health to look at the real numbers. There is a district, a small city called Tarutung in Sumatra. We saw that the district has no cath lab at all. And then the 5 adjacent districts also, they don't have cath lab. So feasibility wise, if we compare with Kendari, this should be a making sense project. That we could put a so-called cath lab and then gaining a good business over there. However, after 2019, we thought that if we just open up cath lab and then there would be, without BPJS support, there won't be any patients.
There won't be
because
anybody.
Because like in Kendari, in small city like Taruntung, 99% of the patients are pretty much using BPJS. So if BPJS is not allowing the equipment to be used by BPJS, we don't have any money. Sadly, the decision would be made after only the equipment being installed and then passing all the tests. So BPJS will come. So again, it very huge
You'll have
risk.
to qualify and validate your equipment before
Correct.
BPJS.
Correct.
Yes.
Yeah. So it's a huge risk for us to enter into a new area today. Like we asked the hospital, hey, can you call someone in BPJS, asking them first the approval and willingness to move forward.
Yes.
Other than that, like we are pretty much cannot touch those area. So this should be changed. Government needs to understand that with investor money, Indonesia could be moving faster in the infrastructure area. Indonesia needs infrastructure in the healthcare. Indonesia needs actually to cover the medical so-called bills for the BPJS patients. And we cannot just limit to the bigger cities. It should be done at so-called the smaller cities. Correct. Yeah.
And at very powerful points, right? And so with your persistence, you've actually reached close to 7,000 cath lab patients, about close to 20,000 diagnostic patients, right? And of course, you've gone through this hurdle of, if I may, pushing yourself through the masses of, or the barriers for you to come out successfully, for you to be able to set up something that is meaningful. So how does your collaboration work? So you set up the equipment, you have international collaborations that you're part of at this point in time, because I know that you do deploy equipment from Siemens and GE. Are they subsidized? Is it manufacturer subsidized? Or is it completely funded by SMU Healthcare? That is one part of it. And the other part of it, do you run the cath lab and the other diagnostic labs that you built, or is it actually run by the hospital staff?
Okay. So with Siemens and GE, we don't have any special bargain. So they consider us as another so-called anybody.
Yeah.
So we don't get any subsidy. We don't we are not subsidized also by the government. It's pretty much our investors' money. So it's a big responsibility to my investors and then keep convincing them that hey, regardless all the policy instability, like BPJS back and forth changing of the policy and their involvement in making policies. So I would say with the performance of current SMU, they believe that we could do more. So we are not stopping to expand. The operators of the equipment definitely are the hospital people. So the interventionists and then the nurses. We
mm,
are involving in preparing the consumables.
mm,
And making sure that the equipment is having a good uptime
mm,
above 90%.
mm. Got it.
Mhm.
So you support in the entire you know installation of the entire equipment, the validation of the equipment, and also running of maintenance, whether it's consumables, whether it's solvents, whatever that need to go into making their equipment functional. But what kind of training do you actually deploy to the interventionists or the nurses for them to able to successfully manage this the lab?
Yearly, we have a big seminars gatherings, and
Mm,
this year, after the big COVID times, after the past pretty much 2 years, we have also the face-to-face
mm,
seminars again in
mm,
Jakarta. So we bring in and we finance also for them to come to Jakarta, and
mm,
then
mm,
having, I would say, the good educations and
mm,
refreshing the
mm,
knowledge as well. So that's yearly. In between, we actually also having like webinar. We bring in senior interventionists to speak up, to share their knowledge, and
mm,
also we have classes that we collaborate with Harapan Kita, a
mm,
central cardio
mm,
hospital in
mm,
Jakarta, to
mm.
support the improvement of the technical skill for the
Mm,
nurses as well.
got it.
Yeah.
That's amazing, Ed. Um, Ed, digital is becoming a topic of conversation across every aspect of healthcare, right? Um, how has SMU healthcare um, imbibed digital in its rollout, in its implementation? Uh, you mentioned a few aspects around training as well as maintenance. Are there other aspects of digital? And if you can give me a sense of, because I strongly believe that digital as a means to increase access would be a key way to succeed in a low capex intensive model. Are there innovative disruptions, whether it's in cath lab or in the diagnostic lab space, where you're exploring digital ways to reach a farer, a larger so-called audience?
Okay. We are considering to have, like they call it PACS,
Mm,
PACS.
mm,
So this is a system where we could actually capture the scan
mm,
of a patient, and
mm,
then there would be more than one interventionist could
mm, mm,
do second opinions.
mm,
Uh, I would say this is going to be very nice, and then giving better clinical advantage
mm,
for so-called the interventionists
mm,
in the field
mm, mm,
by, let's say, getting additional valuable insights. But I don't think it's going to be working at the
mm,
Indonesian cultures. We
mm,
try
mm, mm,
as we approach couple of interventionists, they don't pretty much like on getting second opinion. Well,
mm.
again, it's a culture. I could
Agreed.
just say about Indonesia. So not that we abandon that project, but we, just going to find a champion interventionist that have an openness toward this
Mm.
kind of so-called approaches.
There are also AI solutions that are reading scans now, right?
Correct.
And a lot of hospitals are piloting some of these AI solutions.
Mhm.
Um, I understand the hesitance or the reluctance to have another interventionist as a peer to read this, right? There's always that what if I'm wrong,
Yeah,
right?
yeah, yeah.
Um, and I understand that culturally, right?
Uh-huh.
The ego of a practitioner, if I may.
Mhm.
But um, is AI also being explored as an avenue?
Yes, we did explore with a software company.
Mm,
They have a good AI, and then
mm,
this AI has, I would say, great capability
mm,
on giving the clue to the
mm. Yeah,
interventionist
yeah,
on how to manage certain blockades.
yeah.
Um, then it goes back to the cost of acquisition of this
Mm,
digital
mm,
software. We
mm,
calculate and then we think that, wow, if we implement this AI in the
mm,
BPJS
mm,
setting with the
mm.
current tariff, we cannot make any good
Cannot
money.
make it.
Yeah.
Yeah.
So again, it's not yet a done homework. We don't pretty much cancel that idea. We are waiting to sit together with BPJS. We are going to actually ask them, why don't we create another so-called special tariff with several assessment being made by this AI, we could get certain kind of reimbursement. Again, BPJS needs to involve in so-called caring toward the outcome of the procedures instead of just caring about how fast they could so-called pay the reimbursement.
Mm. So it comes back to, because that'll be powerful, right, Ed, to have an AI assisted reading that's
Life
done.
saving, I would say.
It's life saving, right?
Yeah.
I was just talking to a player in India right
Mm,
now, right? They are able to read uh, just by taking a picture with
mm,
your phone. They are actually able to see whether you have a cataract, you're
mm.
progressing towards a cataract,
Okay.
and what stage you are. Imagine the flexibility and the power of uh, of reach if you're able to do that.
Mhm.
So similar to that, over here you were talking about capability issues, you were talking about manpower issues. If AI assisted cath labs or diagnostic centers become a reality, of course, with the right checks and balances, with the right regulatory framework,
Mhm.
I think it can be an amazing advantage to a place like Indonesia, which is so far flung, and the islands are so separated from each other.
Correct.
Um, uh, Moving slightly into scaling the solution that you currently have. What are your plans for SMU healthcare, and what do you see? And you spoke about a few aspects around resistance and what is stopping your growth. But what is your end vision, and what is your North Star for SMU healthcare?
Okay. These days, I believe the Ministry of Health is giving more support toward
Mm,
the regional hospitals.
mm,
And like I would say, I'm hearing that the budget are easily approved.
mm,
So it's good. Like they
mm,
could actually own cath labs,
mm,
CT scan, MRI, Linux, and everything else. Again, our mission is we are not going to be stopping only on providing the three modalities that we are having today: cath lab, CT scan, MRI. We are
mm,
branching out into radiotherapy as
mm,
well.
mm,
Even as you said, the like phaco
mm,
equipment for the
mm,
cataracts,
mm,
ESWL for
mm,
the kidney stones.
mm,
We are actually trying to do something more than what we have. Again, it's going to be involving with careful feasibility
yeah,
studies. Yeah,
yeah,
we
yeah.
have to be able to read what BPJS has in mind.
Mm,
Let me give you an example on a hospital
mm,
that I was with.
mm,
It's second tier cities.
mm,
We bought a FACO equipment. It
mm,
cost us about 3.5 billions Indonesian
mm,
rupiah.
mm,
After we bought, again, it doesn't need to have a special BPJS
mm,
approval,
mm.
and the hospital get only a quota of maximum 15 patient a month.
Mm.
Wow,
Oh,
you're like,
wow.
yeah. So it's a bit sad. We
Yeah.
invested that much, but we receive a quota, and we don't understand why this quota should be there. Well, if maybe BPJS is a private institution, they care
Mm,
about their EBITDA. Maybe
mm,
that's the way. Again, BPJS should not be playing on focusing on their EBITDA. They should
mm.
be focusing on how fast, how big the access toward the populations. That's the homework of BPJS. I would say now BPJS is just moving toward let's be profitable instead of
Mm.
hey, let's create access.
That's amazing. So you are actually moving towards oncology, you're moving
Yeah.
towards nephrology.
Mhm. Mhm. Yes.
And at this point in time, is there a plan already, Ed, that you're
Mhm.
going after in terms of where exactly you're thinking about the next maybe the PET CT scan
Okay.
machine that you're going to be deploying?
We have a couple of pipelines already. We
Mhm.
have pretty much in talk, especially for the radiotherapy. We have not signed any contract, but we have two hospitals that
Mm,
are in talks. And then because investing in radiotherapy is not only buying the equipment, we have
mm,
to create the proper bunker.
mm,
So
mm,
uh,
mm.
fortunately, these two hospitals they don't have the bunker yet, so
Yeah,
we have to do another so-called calculations to create investment in the bunker area. So again, this is going to be exciting. Radiotherapy is also a more regulated area
mm,
compared to the other
correct,
equipment.
correct.
This is not going to be easy, so we are pleading also to BPJS, to the Ministry of Health, and to the Ministry of Investment as well to give us a certain kind of uh, like favorable policy. So
Got it.
we, yeah, I mean, the money is ready, the willingness there, and then we see the need as well. So combining those three, we need the support, and then like making sure that we don't need to wait for 1 whole years just to create a new radiotherapy center in Indonesia. So
Got
now
it.
it's about 1 year to get
Got it.
everything done and run.
Wonderful. So,
Mhm.
just from your operating model standpoint, right? You are, of course, working with the government hospitals, you're working with BPGS, you're working with MOH, and of course the investors that are backing your company to make sure that this happens. Have you also had collaborations with big pharma players who are actually marketing and distributing their drug for, let's say, cardiac related ailments? So because what we are seeing is, so for example, based on my conversation with some of the big pharma players,
Mhm.
they want to improve their use and adoption of some of the medicines,
Yeah.
right? Some of the innovative medicines that they have. And some ways is, of course, supporting labs like or institutions like you to help establish a diagnostic center which will allow for prescription of some of these critical medicines. Have
Mhm.
you gone that route as well? Have you explored that route, Ed?
The answer is yes.
Mm,
Since 2 years ago, we have
mm,
been in talk with a Japanese consumables
mm,
company.
mm,
They have currently a production facility in China.
mm,
So we actually talk with them. Hey, what if you set up also production facility to produce stent
mm,
balloon
mm,
in Indonesia?
mm,
And then I was having a meeting with the Ministry of Health. Back
mm,
then was Dr. Terawan as
mm,
the
mm,
minister.
mm,
So we talk about the support from the
mm,
Ministry of Health.
mm,
The support I would say was not small.
mm,
They
mm,
even mentioned that they would actually lend us a big land
mm,
for 30 years,
mm,
so like the company could build
mm,
up the production facility.
mm,
And the ambition is, hey, what if this production facility could help BPJS to
mm,
lower their costing as well. Again,
mm, mm.
with all imports, like, I mean, 100% we have imported consumables today.
Exactly, exactly,
So
exactly.
what if the Indonesian production facility could be able to provide the local needs. I mean, local needs of 275 million population is a lot already.
Is it?
And even the ministry was having an ambition of, wow, okay, we have the big needs. It's a good idea to have the local production. And then what if we could also export the production
Mm,
using the Japanese brand? It was a very good discussion, good ideas. But again, the
mm.
minister changed, so we have to start over
Yes.
again.
Yeah.
So it's going to be a continuing fight on our
Mm,
side, and we believe that this is going to be also another good sideline business
yeah.
aside of our PPP project.
Fascinating, Ed. And it looks like you have some exciting, paths that are charted out for SMU Healthcare. Um, as we come to the last few minutes of our conversation, I wanted to summarize a few things for our listeners, whether it's an enthusiast who wants to understand health, whether who's a potential investor who's trying to break into the healthcare space, or whether it's an establishment that exists right now that is trying to enter into the BPGS segment. My conversation, whenever I talk to any healthcare leader or any investor or a government, is you can't serve Indonesia without serving BPGS, right? There's only so much you can grow. Then you'll have to you'll probably reach a threshold after a certain point. So, what, according to you, are the 5 important aspects to get BPGS hospitals to not just be efficient, but also improve their clinical superiority? There are 2 aspects of it. One is, of course, the BPGS hospitals themselves, and also the private hospitals who are serving BPGS patients, which need a different operating model for them to be able to be successful. So what are your 5 key mantras or important aspects to make this successful?
Okay. Five. Okay. We could start with the first one, that the top management of that hospital, and then supported by the medical teams, including the nurses, the radiographers, lab technicians. They need to believe that BPJS patients has no different status than the premium patient. And they should be able to think that, again, majority of the patient would be, there are BPJS patients. No one could deny that. So why should you have a mindset that, hey, why we should treat this less? I would say it starts with the mindset. Let's change that. When you change that, when the hospital management and then the so-called nurses, the medical team change their mindset, their behavior is, I would say, would be more positive toward the care services and the impact toward the clinical and then toward, I would say, patients getting better would be achieved, I would say, a bit faster, comparing that, well, like you are not so-called paying customer, I don't need to prioritize you. Again, talking about the priority, like, hey, whoever check in first, like they should be treated first.
Similarly.
Similar. And like during my time with Unimedica, one of the speech I made to the team is, hey, consider those BPJS patients are your immediate family. Are you going to treat them like that? So change the mindset. And secondly, more specialists should be added to most of the hospital in Indonesia. So this is not a homework of the hospital, but this is a collaboration between MOH to give permissions to the private universities to graduate specialists. Now it's pretty much monopolized by like the national hospitals, the government university. Well, Indonesia is just too big, more graduates in the specialists and also more graduate for the nursing capacity. And the third, we also need to have the support by fixing the regulations when like adding specialists into certain district, it should be approved by the local associations. Only it doesn't make sense. Like this is creating another barrier for us hospital to better their clinical delivery toward the patients, while it's being blocked by I cannot say all, by several let's say cardiologists association, because they don't want to have more cardiologists inside of the district. I just could say plainly that they try to preserve their revenue, sadly. So they don't think big, they don't think about the community, they don't think about so-called making sure that the region having a better kind of service. And number 4, government needs to collaborate with private institution, like we have it in Indonesia, like Summit. Summit is providing training, like medical training, certifications, not to ridicule the government intention, but they don't have the capacity to provide this kind of services throughout Indonesia. So this is important that they are allowing private institutions and then maybe supported by a subsidy, so they could walk to all Indonesian hospital, private, government-owned, and then making sure that the clinical delivery is up to the standard. Now everybody is talking about the standard, but again, I'm questioning myself. Are we using Australian? Are we using Singaporean? Are we using American? So everybody has pretty much that kind of mindset, and there is, I would say, not yet a same understanding being done by the ministry. This is the new standard, and then this is what should be done for the better of Indonesian hospital. Definitely, number 5 is supporting the availability of specialists in the second tier and actually beyond second tier cities as well, smaller than second tier. Government needs actually to create a good incentive. So private hospital is not having a challenge. Today, specialists in smaller cities, they work as government employee, 8 to 5. So they register the time slot 8 to 5 into government hospital, and the remaining before 8 a.m. and then after 5 p.m. They could work in the private hospital. So like private hospital thinking is, wow, okay, it's not going to be working this way. So they have to import the specialists from the bigger city. Again, importing means that they have to pay premium for that portion. So government needs to keep supporting in the area of the availability of the manpower in the second tier cities.
So great points, Ed. Wonderful. On that note, Ed, I think that's a powerful note to wrap this conversation on. And your conversation the last 60 minutes has been so insightful, and more importantly, there's so much passion and drive with which you're trying to make the change for Indonesia and Indonesia's healthcare. So was an absolute pleasure, Ed, to have you on the Health4All podcast. I'm sure all the listeners would enjoy the last 60 minutes of our conversation. So thank you again, and I look forward to having you again on this show on a different topic, and probably when your nephrology and oncology centers are up and running, right?
Okay.
So all the very best, Ed, and look forward to talking to you more.
Thank you, Sana, for inviting me.
Wonderful.
Have a good day.